My name is Steve Yetterberg. As I was introduced, I am a retired rheumatologist from the Mayo Clinic, and we have notes saying that they are seeing things. That's good. So the title of my talk is Myositis 101, and it's probably going to run a little long, but there will be time for questions. If I can get my screen to move. I do some consulting work involved in some studies. And to start, so I'm going to try to get some basics about myositis. One of the issues is that, I'm sorry, the screen keeps popping up in front of me, of understanding these diseases. So classically, meaning back when I was still in medical school, I graduated from medical school in 1976. This seminal paper was published in 1975. And in this, inflammatory myopathies were split into two disorders, basically, polymyositis and dermatomyositis. There was a juvenile form, basically dermatomyositis, and then adults could have isolated poly or dermato, or have myositis associated with malignancy, or myositis, either one, overlapping with other autoimmune disease, such as lupus or scleroderma. And so it was easy. There was polymyositis, there was dermatomyositis. Nowadays, when we talk about inflammatory myopathies, we've got this whole list, and most recognize these five: polymyositis, dermatomyositis, inclusion body myositis, anti-synthetase syndrome, and necrotizing myopathy, or immune-mediated necrotizing myopathy, some call it. So we went from 2 to 5, and we're going to try to cover a lot here. I'm going to start by trying to answer some questions to sort of preclude your questions to me later. What is myositis? What is an autoimmune disease? How do the various forms of myositis differ? And how is it treated? So to start, we'll start going from myositis 101 to Latin 101, that MAYO is a Latin prefix for muscle. And if you think of what muscle is, it is the organ that attaches to bone that allows, or that generates motion because of the contractility. So muscle is made up of individual muscle fibers that are grouped together into bundles that are called fascicles. These fascicles are wrapped by paramycium. And I go through this because I'm going to show you and describe that one of the characteristics of polymyositis and IBM is endomycial inflammation, inflammation in and around muscle fibers. Okay, so this is myositis, is inflammation in muscle. And so itis is inflammation. I jumped ahead of myself. Sinusitis, tonsillitis, etc. Myositis is inflammation of muscle. So muscle inflammation, here is a slide with images from a publication by Andy Mayman, one of our other MAB members, just showing that here is normal muscle that's been biopsied. This is a muscle fascicle, a bundle of individual muscle fibers, and they're all packed tightly together. This is a biopsy from a patient with polymyositis, and this shows, as I mentioned, endomycial inflammation. So here is a fascicle. This would be another fascicle and a part of another one here, and the inflammation is all around individual muscle fibers. Here is a biopsy from a patient with dermatomyositis, and this shows perifascicular atrophy. So again, here is a fascicle, here is another fascicle, so a group of muscle fibers, and these are packed nicely together, but the ones out here at the edges, at the periphery of the fascicle, are small, they're atrophic, and this is one of the characteristics of dermatomyositis. Inflammation is not as intense and tends to be between the fascicles and not in them. So right here is an example of the fact that these are different diseases. It is not that dermatomyositis is polymyositis with a rash, but these are different disorders, different things are happening in them. So the last one on the list that I showed you before was necrotizing myopathy. And this doesn't have an itis. Apathy means abnormality of the tissue or organism. It's a more general term. And myositis is one type of myopathy. So by saying that necrotizing myopathy is not a myositis, implies that there is no inflammation. So myositis, myopathy, to get those straight. We're going to move on now to Immunology 101, because these are autoimmune diseases. And I think that to understand what's going on and therefore how things are treated, you need some basic understanding of autoimmunity. So what's the immune system? Talk about autoantibodies and then causation. So these are autoimmune disease. Autoimmunity means the immune system, instead of looking to fight off outside invaders, is misdirected and ends up attacking the body itself. So I found this nice image from the web to use. There are two main halves to the immune system, what we call innate immunity and adaptive immunity. So innate is the built-in type of immunity or natural immunity. It comes on quickly. I like the image of this little pathogen, this bad guy trying to sneak in. It's identified by antibodies that had been made previously. We'll get into those. And that activates this complement stuff that causes a lot of inflammation. The bad guy is also identified by these natural killer cells, this grumpy looking thing. And that stimulation leads to a host of inflammation markers that are signals that go up also. It also interacts with these dendritic cells. The dendritic cell is important for moving from this innate immunity that is non-specific, doesn't care if you're a virus, a staphylococcus, a streptococcus. It is something that's bad, we've got to act on it. Move into the adaptive side is to say, gosh, this is influenza A, this is influenza B, this is coronavirus. So this is very specific. And the dendritic cell is really the mediator getting from the innate to the adaptive. And I tell you this because there's a lot of research now showing that dendritic cells are producing a substance called interferon, type 1 interferon, that seems to be one of the main signals in dermatomyositis especially. So these are cells in the immune system, but they're also potential targets. We have drugs that inhibit this IL-1, IL-6, TNF. Manufacturers are making products that interfere with all parts of this whole process. So the dendritic cells move us from innate or natural to this selective or adaptive immunity. And on this right-hand side, there are actually two parts to the adaptive immunity. One part is through what are called CD8 positive T cells. And these are cells that are programmed to kill other cells. So specifically, a cell that's been infected by a virus shouldn't be kept around. So these CD8 cells identify parts of this original pathogen, were processed, moved on, and can identify and kill off infected cells. The other part is through these B cells, and they make antibodies and memory cells, cells that are sleeping basically, but ready to come back very quickly if the pathogen shows up again. And they make antibodies so that they're around and circulating to find the influenza. That's why you should get your flu shot. So antibodies, cellular immunity. antibodies are good, but sometimes there are antibodies directed toward an individual's normal cells or components. And a number of diseases have these: lupus, rheumatoid arthritis, celiac disease. And these antibodies can damage normal cells or sometimes simply interfere, I shouldn't say simply, interfere with the workings of the cell. So again, back when I was doing my training, there were 3 autoantibodies basically that were correlated or associated with inflammatory myopathies. One called anti-SRP, signal recognition particle, was felt to be found in polymyositis, MI2, anti-MI2 in dermatomyositis, and anti-Jo1 was with polymyositis or dermatomyositis in a pattern that's now called anti-synthetase syndrome. SRP's been moved down here, but there are only these 3 basically. Since then, things have exploded. And I show you this only because current understanding of these diseases, of the myositis disorders, is focusing more and more on classifying them based on autoantibodies. And I'll get into these as we go to the other, as I talk about specific diseases, but there are a bunch. These are not specific for myositis. These can be seen in other connective tissue diseases, autoimmune disorders like lupus, scleroderma, Sjogren's syndrome. But the others really don't show up with other diseases. And we'll get to these as we go into the disease specificities. Next, I'd like to talk about causation. And what often had patients ask me, well, why did I get this? You know, I was fine, then I was sick. What happened? It had to have been something. And basically, we don't know. Most of us think that there are a couple of things that are needed to develop autoimmune disease in general, including myositis, that you have to have some genetic risk, and there has to be something that triggers it, something that is in the environment most likely. Now, it's possible that other people are exposed to a factor that might trigger it into a susceptible person, but they're not susceptible, they don't get disease. Similarly, there are a lot of people who might have the genetic risk who aren't exposed, they don't get disease. So it seems sort of the going theory is that it's a 2-step process. I only have one study that I'm going to show you. This is a study looking for genetic associations, genetic features associated with dermatomyositis. So this was both juvenile and adult dermatomyositis patients. And there was a very strong association with this MHC site. Now, this is part of the immune system and how the body recognizes self from non-self. So again, this points strongly to the immune system as one of the genetic changes, or I shouldn't say changes, but the genes that you have that specify what MHC markers you carry. There were some other genes that showed up, but by far the strongest was with these markers from the immune system. From the environmental side, what exposures are linked? Well, the operative word here is linked, not proven. Probably the best example is ultraviolet light exposure. It's very clear that for some patients with dermatomyositis, their disease can flare because of sunlight exposure. And so that is an environmental exposure that is pretty clear. There's been some work to suggest that perhaps cigarette smoking may have some risk for anti-synthetase syndrome. And silica from rock work, mining, has been linked to a number of autoimmune diseases. We've looked for a long time for infections and can't find an infectious trigger. So that was my quick autoimmunity. Overview of the immune system, autoantibody introduction, causation. I'm going to spend a bit of time talking about the various forms of myositis and how they differ. So I showed you this earlier: polymyositis, dermatomyositis, IBM, anti-synthetase, and necrotizing myopathy. Because this is a myopathy, I sometimes take this I for inflammatory out and put immune mediated in, so I can still call them IIM, a term that's been used by many for a long time, but these are immune mediated, if not inflammatory. So here was the start. I put this back in just to, again, mention the risk for malignancy. There is an increased risk of malignancy in patients with myositis. And it's, as I'll show you, there are some of the antibodies in dermatomyositis that point to even more increased risk. But paying attention or thinking of myositis risk, of malignancy risk in patients with myositis is important. The other is to recognize that these disorders can overlap with other autoimmune connective tissue diseases. So to think whether there might be something else going on. Once you have one autoimmune disease, you're more likely to get a second than somebody who has none is to get a first. So this was just to remind me to mention other organ system problems. Lung, with interstitial lung disease, one of the hallmarks of the anti-synthetase syndrome is one of the most concerning. There can be gastrointestinal involvement with swallowing difficulty, reflux symptoms. Heart inflammation of the heart muscle is a rare thing, but has occurred. Rhythm disturbances, in joint inflammation. This Raynaud's phenomenon is when fingertips turn blue or purple on cold exposure. Fatigue, fever, and I also already mentioned the malignancy risk. So back in 1975, the things that we expected to be able to make a diagnosis of polymyositis or dermatomyositis were the presence of proximal muscle weakness, so the muscles around the shoulders and hips, elevated blood levels of muscle enzymes, CK, aldolase, AST, ALT, and LDH. These AST and ALT are classically liver enzymes, but they're found in muscle as well. There's more of them in liver, and when they go up, people often think liver disease. And I've seen patients who even had a liver biopsy looking for liver trouble when they actually had myositis. It's just that the weakness had not become very apparent, and nobody thought to look for CK elevation. We'd do an electromyogram, and the gold standard really was the muscle biopsy showing inflammation. And if there was a rash, then we'd call it dermatomyositis, although it's not just any rash. There are some very specific rashes that I'll show you, and there are some very specific features on skin biopsies. So that was back then. Now we've got all these different forms, not just dermato and poly. I've moved polymyositis to the bottom on purpose, and I want to walk through these and end up with polymyositis. So dermatomyositis, what differentiates it from the other disorders? Well, there's the rashes, and I'll show you Heliotrope and Gottron's papules in a moment, but these are rashes that don't occur with other diseases. So these are felt to be very specific for dermatomyositis. The biopsy showing this perifascicular atrophy doesn't occur with other disorders. And then specific autoantibodies that are now found that have really only been around for, other than the MI2, over the past decade, more or less. So here is an example of the heliotrope rash. This is from the American College of Rheumatology collection, but it's not the greatest. So it's usually described as a lilac-colored rash over the lids, often difficult to see. This is Gottron's papules. It's a shiny, scaly rash over the knuckles. So this set of knuckles, the far out ones that can occur over the elbows and on the knees as well. So those are the two that are most specific for dermatomyositis. Sometimes it doesn't have the scale, and we'd call this Gottron sine. This is called a shawl sign, and it highlights the rash in sun-exposed area. Changes to the small capillaries in the nail bed can be seen. And finally, an example of calcinosis, or calcium deposition, that can sometimes be felt as lumps under the skin, but shows up quite easily on an X-ray. And then there are the dermatomyositis specific autoantibodies down here. So MI2 was or anti-MI2 was the first one described. These two, NXP2 and TIF1 gamma, are the two that have seem to have an increased risk of malignancy. So when patients are found to have one of these two, we want to look even harder for cancers. This NXP2 antibody tends to associate with the calcinosis that I just showed you. And what's important about the MDA5 antibody is that it is associated with lung disease, interstitial lung disease, like the synthetase ones, but it often is very rapidly progressive. This antibody seems to show some racial differences. It's found more frequently or described more frequently in studies done in Asia. So the antibodies, and basically if these show up in the right rash, essentially nowadays makes the diagnosis of dermatomyositis. Now things get a little more complicated because there are patients with what's known as amyopathic dermatomyositis. So this is dermatomyositis that doesn't have muscle pathology, or dermatomyositis sine without myositis. So patients diagnosed with this have the skin features of dermatomyositis and biopsies that are consistent, but have no muscle weakness. Sometimes they may have some elevation of muscle enzymes or maybe an abnormal EMG that would be accepted, but no weakness. What's important is that these patients still have risk for non-muscle problems, including interstitial lung disease and malignancy. We'll move to inclusion body myositis. And there are two general forms, hereditary being much rarer than sporadic inclusion body myositis. As the name implies, it runs in families, tends to have a younger onset than sporadic IBM, which has onset into the 60s, sometimes earlier, but typically older onset. And there is no inflammation in the hereditary form, but it looks just like the sporadic when you see patients with it. So with sporadic IBM, the differentiating features are the slow onset and progression compared to other forms of myositis. Others more often will have symmetric weakness. The patients will be just as weak on the right as on the left. There's more asymmetry in patients with IBM. And there's eventual development of weakness in the flexors, the grip strength in the hands that doesn't occur with polymyositis or dermatomyositis, as well as knee extensor weakness. Importantly are the inclusions in the biopsy that give this its name, inclusion body myositis. So they see what are described as rimmed vacuoles, other inclusions. And lately, or recently, a autoantibody has been described. So here is an example of profound atrophy of thigh muscles, weakness of the finger flexors, about 6 years from symptom onset to diagnosis, and swallowing difficulty can be seen in up to 2/3 of patients. This is a slide showing muscle biopsy stained to show these vacuoles in the muscle fiber. And this is the autoantibody called anti-5-NT1A or CN1A, has a couple of different names. It is not as specific as most of the others because sometimes it is described in patients with Sjogren's syndrome. But what's of interest is that Sjogren's syndrome another autoimmune disorder, is not infrequently seen in patients with sporadic IBM. Okay, anti-synthetase syndrome. So the differentiating features are the clinical features, especially the interstitial lung disease, but the full sort of spectrum of anti-synthetase syndrome is a patient with myositis, what looks like polymyositis or dermatomyositis, with interstitial lung disease, inflammatory arthritis, the Raynaud's, fingers turning colors, low-grade fevers, and mechanic hands. Some say that there are some specific features to the biopsy, and there are these autoantibodies that I'll get to in just a second. But here is an example of mechanic hands, sort of this dry, scaly, crusty, cracking skin over the palms and the fingertips. And these are the anti-synthetase antibodies. They get their name because of they're directed toward what are called tRNA synthetases, and there's a family of them because these are for different amino acids. So each amino acid has its own tRNA synthetase. The most common of these is JO1, seen in about a quarter to a third of adult patients with myositis. JO1 is less frequent in African Americans at about 13% compared to Caucasians. But African Americans tend to have some of these others that are, that are less frequent in Caucasians because they get up to about the same frequency overall. So there's a bunch of these. They basically look about the same. There have been some recent studies describing subtle differences between some of these and the JO1, the most common one. But they're basically, the concern is the interstitial lung disease. So necrotizing myopathy, or immune-mediated necrotizing myopathy. Differentiating features here, clinically subacute onset, so not abrupt, but not as slow as polymyositis, dermatomyositis, and certainly quicker than IBM. And there's often very severe muscle weakness. The biopsy shows necrotic muscle fibers with no or at most minimal inflammation. And it's really characterized by autoantibodies, the anti-SRP, signal recognition particle, and anti-HMG-CR, or HMG-CoA reductase, which is the target of statins. There are patients who don't have these antibodies, though, but just have necrotizing myopathy on biopsy. And here is, from that same paper I showed before, an image of a biopsy from a patient with necrotizing myopathy. Now you're going to say, well, gee, there's blue stuff in and around these fibers, just like here, but on higher magnification, these are different blue cells. These blue cells are white blood cells that are doing things. These are the lymphocytes attacking muscle. These are actually scavenger cells called macrophages. And there are dying fibers without the inflammatory cells around them. And then the macrophages come in to clean up, basically. And here are the antibodies that go with necrotizing myopathy, this anti-HMG-CR and anti-SRP. The SRP in particular can be associated with swallowing difficulty or dysphagia and severe myopathy. Now, what's of interest is that HMG-CR, HMG-CoA reductase, is the target of statins. And statins are known to cause muscle trouble, but mostly it's reversible muscle trouble from statins. This is a relatively common thing, although, knock on wood, I've had no trouble with mine. Typically, patients experience muscle aches and can have elevation of CK, but it's usually not very high. The symptoms, CK elevation, improve when the drug is stopped, and patients with these reversible side effects do not develop the anti-HMG-CR antibody. Conversely, Statin-induced necrotizing myopathy does not improve with discontinuation of the drug. So if the patient was on a statin, develops the HMG-CR antibody, stop the drug, this antibody continues. So we've gone through all the rest of them, and all that's left is polymyositis. So it gets to the question of what is polymyositis? So back to what I showed you before, how did we diagnose it back in 75? Proximal muscle weakness, elevated muscle enzymes, biopsy. The EMG is not specific. It was included in the original criteria. I don't see as many EMGs done today as used to be. I still typically did them. But there's nothing specific here, the way there are specific things for the other forms of myositis. So basically what it comes to is polymyositis is an inflammatory myositis characterized by a biopsy showing inflammation, elevated enzymes, proximal muscle weakness, that does not have any of the features of dermatomyositis, that does not have features of inclusion body myositis, and does not have features of necrotizing myopathy. And I left off, does not have the anti-synthetase antibodies. How did I go through this so many times and miss that? So I tried to walk through the different forms of myositis and myopathy, and it just leaves treatment. I know I'm going a little longer than the half hour I was supposed to do, but let me do this. So this is really my take on why we use the drugs we use to treat these diseases. And this should say, yeah, I repurposed this from a different talk, and I apologize, because this is really all of these disorders. This is underlying as an autoimmune process. And what we would like to know is, could we identify what is the inciting factor? If it's a virus, maybe we could immunize for it. So if there's no infection, there's no disease. If it's something else that can be avoided, perhaps we could stop it that way. We're not going to do anything about genetic risk factors, but we don't know what the inciting event is that triggers the immune system to get misdirected. But it then seems to go one of two ways, either the T cell route causing this CD8 positive inflammation and damage to muscle fibers, or the autoantibody effects that would be as in the necrotizing myopathy. With this going on in the muscle, patients develop symptoms. So we want to treat to help the current symptoms. I hear this from the patients all the time. We also want to treat, however, because inflammation and other things going on in the muscle can damage muscle. And muscle has the ability to regenerate up to a point. And if it gets damaged enough, it can't regenerate. So damage by definition is irreversible. So we want to prevent damage at all costs. Things get difficult when trying to interpret a patient's symptoms. If they've been treated for a while and they're still weak, are they still weak because there's ongoing inflammation? Or are they weak because there's been damage to muscle and that muscle's not going to come back, and hence the weakness? And if that's the case, more treatment isn't going to help. So it takes some astute looking to try to decide, do you do more treatment or do you back off to avoid side effects? Because all of this is weighing the pros and cons. There's risk to everything. There's risk to over-treating and getting side effects. There's risk to under-treating and letting damage occur. And the overall approach is to use steroids to quickly try to quiet inflammation. So glucocorticoids are also called, prednisone is what everybody knows and hates. And then to use some immune suppressing strategy to quiet the immune system to then let us get by with less of the steroid. And sometimes we need symptomatic treatments. Say a patient with the anti-synthetase syndrome who has fevers, Tylenol might be helpful for the fevers, but it's not going to do anything to the inflammation or the autoimmune process. So this is my sort of general view of what we're doing and why we're trying to do things to treat. Prednisone, most advocate starting treatment with high doses of prednisone, usually defined as 1 milligram per kilogram per day. Sometimes we'll use intravenous boluses to jumpstart the treatment. The same dose split up gets more effect. So 60 milligrams once a day has less effect than 30 milligrams twice a day, or 15 4 times a day. I usually do the starting dose for about a month and then begin to taper. I always use an immunosuppressive agent right up front along with the steroid to try to allow the prednisone to come down quicker. And then it's to be attentive to side effects, osteoporosis, infection. And so everybody has their own way of tapering. I usually tried to get down to 10 milligrams a day after a few months, after several months. And then it's to try to see how things are doing. Do we keep going down or what? And then it's to use immune suppressing drugs. And this was my view of looking at them, that these were my first line agents. I put hydroxychloroquine, yes, that hydroxychloroquine in here because it can be very helpful for the rashes in patients with dermatomyositis. It doesn't do anything for the other forms of myositis or the muscle disease in dermato, but for skin involvement, it can be helpful. But the first line immune suppressing drugs are methotrexate, azathioprine, or mycophenolate mofetil, also known as Cellcept. I usually, and a lot of it is because of cost. Moving on to the others, they tend to be costlier or have more risk. So second line agents, IVIG, I use it sooner for patients with severe swallowing difficulty, patients with bad skin disease and skin, ulcers in the skin. Rituximab is, although its so-called pivotal trial failed, it is recognized as being effective. Tacrolimus, cyclosporin, leflunomide. Cyclophosphamide, or Cytoxan, is a potent drug suppressing the immune system, and we sometimes use for severe life-threatening disease. And plasma exchange or plasmapheresis has been shown to be not useful in polymyositis and dermatomyositis, but it can remove the autoantibodies, and there are some descriptions of it being helpful in severe necrotizing myopathy. But there is hope. There are a lot of things that are being studied. Many of these are drugs that were introduced for other uses, often rheumatoid arthritis, abatacept, tocilizumab. These are targeting a number of those things that I showed you way back on the immune system slide, that these target IL-1, one of the specific, I'm sorry, IL-6, one of the specific inflammation signals. This, I didn't get eculizumab, is targets complement. Linabisum is being studied currently in dermatomyositis. It made the news lately. The company that makes it, stock dropped 75% this week because a study of it in scleroderma failed. But there's still hope with dermatomyositis. But there are a lot of things that are being looked at. These bottom few, the bimagrumab, rapamycin, and arimoclomol, I can never say it right, arimoclomol, are being evaluated in inclusion body myositis. So the last things to remember, pneumocystis prophylaxis is very important. Pneumocystis pneumonia is a bad form of pneumonia that's linked to the use of high-dose prednisone, much more so than the immunosuppressive drugs. So having patients on prophylaxis while on high-dose prednisone, I think, is very important. Having patients get vaccinations, influenza, pneumococcal, other immunizations, attention to osteoporosis because of the prednisone, mobility and assistive devices, fall prevention, things to address dysphagia, and finally, exercise has been shown to be beneficial for patients with myositis.